introduction. So I'm Brett Dragmer. Can everybody hear me all right? Good in the back? All right. Yeah, so I'm Brett Dragmer. So I'm new to Louisiana. I've been here for about a year. Very excited to be down here. And as we start opening back up, excited to get to explore more. But I'm going to be here today talking about implementing interventions based on the NHSN antimicrobial utilization data. So just for context, just kind of get an idea of, is what facilities here are actually participating in NHSN right now. Can I get a show of hands if you guys are? Okay, so about half the room. All right, so I think that makes sense. That's about what I'm used to seeing. So basically, we have a lot of data available if you're participating in NHSN, excuse me. But how best to use that, and how do we make that relevant to our clinical practice? And so I have no disclosures or conflicts of interest to report. And the objectives for today will be to identify key SAAR metrics available within NHSN antimicrobial utilization data, to interpret the NHSN antimicrobial utilization data to draw a conclusion about that data set. So we want to make sure that we're able to understand what that data can tell us, what it can't, and what some limitations may be of that data. And then lastly, I'd like to be able to apply the antimicrobial utilization to design an antimicrobial stewardship initiative. So that's the ultimate goal, right? We have all this data available. And when we're thinking about what we want to do next with our antimicrobial stewardship programs, we can have an evidence-based starting point that says, hey, this is an area that is an outlier. I think, to me, that's a great idea as far as designing your next initiative and be able to get buy-in, because you knock down some of the barriers with regards to, oh, well, that's not actually a problem at our facility, or other people are doing that, when you can show them the data and say, hey, actually, compared to the nation, you are an outlier in this area. And so we'll go over that. But I think first it's important to talk about what actually is NHSN. So it's the National Healthcare Safety Network. And so you guys are probably more familiar with this with regards to healthcare associated infections. Specifically, the NHSN is the nation's most widely used HAI tracking system. Provides facilities, states, regions, and the nation with data needed to identify problem areas, measure progress of prevention efforts, and eliminate healthcare associated infections. And so that is the primary use of this. It does cover a variety of facility types, so acute care hospitals, inpatient rehabilitation facilities, long-term acute care hospitals, and really looking at the infection prevention as well as the hospital-acquired infection side. So CLABSIs, CAUDIs, ventilator-associated adverse events, SSI, C. diff, as well as MRSA bacteremia. But the focus on today's talk will be about the antimicrobial utilization module within the NHSN dataset. So what is this module? So the objectives of this module are primarily to facilitate risk-adjusted inter and intra-facility benchmarking for your antimicrobial utilization data. So what that means is the NHSN wanted to provide a national benchmark to be able to compare to other facilities that participate. And also, if you are part of a multi-hospital system like I am, so we have 19 facilities, to be able to use that data to not only benchmark against the nation, but also to compare against your facilities within that you're going to have access to. Secondarily to that would be to evaluate antimicrobial use trends over time at the facility and national level. So having that benchmark, so that's going to be the SAA part, which we talk about shortly, as well as the ability to track changes over time. So I think this is really crucial with regards to looking at not only what you should be starting with, but are the interventions that you're making effective in the long term. So we can have the best idea in the world. I can start a new targeted initiative, but if it's not actually moving the needle, then it's not really doing anything for our patients. And so this gives us a more reliable way and a more consistent way in order to really see, are we seeing changes over time? And allows you to demonstrate the fact that maybe your initiatives are working, but also that you're maintaining that progress. So that's another thing that I think is really relevant with regards to this data set is, as you roll something out, is it durable? So we can have a very targeted education effort, roll out a lot of activities, but then is that resulting in just a 1 to 2 month decrease before everybody's kind of going back to what they were doing, or are we able to sustain those interventions over time? And so that's another benefit of this data set of participating in this module. But participation is optional. So as you can see, we had about half the room that is currently participating at the facility level. So personally, obviously, I'm giving the talk today, but I think this is a great module. So I would strongly encourage any facilities that aren't participating, if you can work through the barriers needed, to participate, it's a wealth of data that's available, and you can really do a lot of it. But there are some requirements that come into play, and that's where some of the barriers can be to participation. So specifically, manual data entry is not allowable for this format. So you do have to have automated IT solutions, thank you, in order to be able to participate within this. And so the requirements are that there is a pre-specified data format, and it has to be integrated into the electronic health record. So generally, there's software solutions that are available through your EHR platforms. There's also third-party solutions that are available. So there's a variety of ways to participate within it, but it does have to be a software solution. It can't be manual data entry. So what actually are the components of this AU module? So specifically with days of therapy, so DOT, and the denominator of this is going to be 1,000 days present. Then there's also the secondary component, which is the standardized antimicrobial administration ratio. And so this ratio is going to be similar to ratios that you would see within NHSN for healthcare acquired infection prevention. So like your SIAR, your SAARs. So kind of similar concept, which we'll talk about. But first, starting about days of therapy per 1,000 days present. And so what this is it's the primary metric looking at antimicrobial days per 1,000 days present. And the way an antimicrobial day is defined is any amount of specific antibiotic administered in a calendar day to a particular patient. So this isn't dependent on the dose of the antimicrobial used. So some historical metrics would be defined daily dose. And so that's something that a lot of facilities use. But you can have some bias in that if you change your dosing regimen to increase the dose or decrease the dose, you're going to have effects on that metric without changing the amount of prescriptions that the patients are getting. So you're still going to have a patient that got Piptazo that day, but if you're going from the 3,375 to the 4.5 gram as your standard dose, you're going to see an increase in that metric, even though the number of patients that are getting Purposeful and Tazobactam will increase. And so by defining it this way, you're able to eliminate some of that bias, because at the end of the day, what we care about is, did the patient get the antimicrobial that day or not? And so that's really the way it's defined. So the other things to keep in mind is it's a specific antimicrobial definition. So vancomycin, for example, if you define it as a vancomycin day, if the patient received a dose of vancomycin a day, that counts as a antimicrobial day. Now you can pool antimicrobials together to have more than one, to have like a total antimicrobial days of therapy per 1,000 per 1,000 days present. And so with this, patients can, like if you're on ceftriaxone metronidazole, for example, for like an intra-abdominal infection. So your individual day of therapy for getting it that day, ceftriaxone would count as 1 day, metronidazole would count as 1 day. If you're looking at the total days of therapy per 1,000 days present, then because they received a dose of each of those, then that would be 2 days present for that calculation. And now, 2 days of therapy, excuse me. So the denominator side of that, though, is going to be days present, which would be the total number of patients in a location or facility each day during a calendar month. And so some important things to keep in mind is this is a unique definition, so it's specific, so it's different from patient days. So days present, meaning that if they're in that facility for any amount of time during the calendar day, they count as one denominator for that unit. So specifically with regards to, let's say, your patient was in the ICU in the morning, they transfer down to the general medical floor. So that would count as a day present for both the ICU and the general medical floor that day. But when you're combining and looking at the facility-wide inpatient metrics, so combining all of your inpatient facilities, that would only be 1 day present because they were still physically within your system for that day. So if you were to add up the denominator for all of your units, that's going to be a higher number than would be for the facility-wide inpatient metric. And that's to eliminate the bias of what we just talked about specifically. So really the definition is important here, and it's important to keep in mind, but at the end of the day, we're comparing it to itself. So as long as we understand the definition to understand the limitations, really as long as you're applying it in the same way, which you are because you're getting the data from NHSN, changes over time won't matter because the definition doesn't change over time. So some other things to keep in mind is that each component is calculated as an aggregate per month. And so the reporting level, the minimum would be a monthly report. You can also aggregate that to quarterly as well as annually. And then the other huge benefit of this system is that the data is obtained direct from the medication administration record, or the MAR. And so this is an advantage compared to other systems, but it's also a requirement. So in order to participate in it in NHSN, you have to be able to obtain this information from the medication administration record. And so that can be another barrier as well, which is why generally those software solutions are needed. But we also increase accuracy because we're not going off antimicrobial orders, we're not going off defined daily dose, we're going off of actual administrations that are confirmed, charted in the patient's chart. So it's going to be the closest reflection of the actual antibiotic use that's entering the patient for that reporting period. And so the way this is calculated would be to take your drug-specific antimicrobial days per patient care location per month. So again, that would be the minimum reporting period would be per month, but you can aggregate this again to quarterly as well as annually. Divide that by the days present per that same patient care location per month. And then this is scaled to 1,000. And so this cuts out the variability between facilities that have different sizes. So scaling to 1,000 allows my facility that may be 600 beds to have the same DOT comparison to a facility that only has 100 beds. So it's getting rid of that volume by scaling it, so we're able to compare the numbers apples to apples. And so just as a quick example calculation for this, for piperacillin tazobactam. So let's say we have 3 patients that are showing up on this unit. So we have patient 1, 2, and 3. So varying regimens, so you can see that patient 1 would be on 4.5 grams every 8 hours for 3 days. Patient 2 on 4.5 grams every 12 hours for 7 days. And then patient 3 on 4.5 grams every 8 hours for 6 days. So the way that an antimicrobial day is defined, the actual dose of the piperacillin for that day doesn't take into account. So there's no difference between the Q8 and the Q12 regimen. The patient still received a dose of piperacillin tazobactam that day. And so for the days present for this unit that we're going to be doing the calculation, there was a total of 175 patient days this month within that unit. And so we take the total of antimicrobial days, which would be 16, divided by 175 times 1,000 to provide that scale, the adjustment for the, the volume essentially. And we're left with 91 days of therapy per 1,000 patient days. So that's really behind the scenes what's happening to allow you to get that DOT number. So the other side of this, and really the kind of the key component of NHSN, would be the standardized antimicrobial administration ratio. And so what this does, the SAAR, compares observed antimicrobial days to predicted antimicrobial days for groups of antimicrobial agents used in specific patient care locations. And so what this means is the formula is going to be, for your SAAR, it's comparing your observed use over your predicted. And so this is where that benchmarking that we talked about earlier comes into play. So you're able to take your actual use, so what your facility is using, divided by what the NHSN data with all the risk factor adjustment predicts you should be using. And so this is where that calculation would come into play. And really, this is risk adjusted at the location and facility level with factors that are found to be statistically significantly associated with differences in antimicrobial utilization rates among the reference population. So what this means is they take into account factors from the benchline. And so for adults, the last benchmark was going to be in 2017. For neonates, it's going to be in 2018. And so, for example, with the adults, what they did is they took your facility type, your number of ICU beds, your percentage of ICU beds. So not just the number of beds, but the ratio to the total beds. They also took your total beds, as well as your average length of stay. Teaching status was another one, so whether you're an academic medical facility or not. And so all of these factors get aggregated to come up with that predictive model. And so for each grouping that we'll talk about, each grouping actually has its own predictive model. So it's specific to the antimicrobials that are grouped together, as well as specific to your facility factors. And so what does this mean? So we get a ratio, right? And we want to know, what can we do with it? And so it's important to understand what this can tell you and what it can't tell you. Specifically with regards to the SAAR, you're looking at a ratio. And so a ratio of 1 exactly would mean that you're using the exact amount in actual use as would be predicted. And so that means that your days observed was equal to your number predicted. However, on the other side, if you have an SAAR greater than 1, so that indicates that your observed use is greater than your predicted. The opposite side of that would be if an SAAR is less than 1, then that would be that you're having fewer antimicrobial days observed than would be predicted. So keeping that ratio in mind, and then obviously degree of elevation above the benchmark would come into play. So let's say we have an SAAR of 1.5. So in that case, what we can say is that your use is about 50% higher than would be predicted. So we'll talk about some of the limitations in the future and what we can really talk about that. But really that's kind of the key point to keep in mind would be 1 would be as much as expected, greater than 1 is more than expected, less than 1 would be less than expected. And so like I talked about, for the adult side, the last benchmark was done in 2017. So benchmarks that are available would include adult medical ICUs and wards, adult medical surgical ICUs and wards, adult surgical ICUs and wards, step-down units, and then general hematology oncology wards. So we have a fairly wide degree of specific locations in order to provide more relevant benchmarking to the unit that you may be working on. So this could specifically come into play if you were focused on one particular unit or if you're working with a unit-based pharmacist in order to really drive appropriate use. Or let's say you have, expected use or use that is higher than expected, and you're wondering where is this coming from. And so drilling down to the location level can help get you an idea if you have one unit that's an outlier or if it's a general overprescribing at the entire institution. So the pediatric baseline is also from 2017 and includes similar units. So your medical ICUs and wards, your med surg ICUs and wards, as well as your general surgical wards. Then in 2018, the neonatal SAAR eligible patient care locations were established. And so this is a separate benchmark. So adults, pediatrics, and neonates all have separate benchmarks. This last benchmark was established in 2018. And it includes step-down nurseries, intensive care, level 2, 3, and 4 NICUs. So specifics within that. Now, with these locations that are available, they're going to be mapped to the standard infection control and prevention definition. So your facilities that are participating in NHSN on the infection control and prevention side, they've already defined how your locations are mapping to the CDC definitions. And so with this, you don't want to have difference in your antimicrobial utilization location definitions. And so they would be standard with the currently defined definitions. Now, obviously, if you have renovations and your unit changes, you want to map that out for all of the relevant NHSN areas for the future once that change takes place. And so there's different groupings that are available. It looks like you guys can see it fairly well on the screen, but I'll go ahead and talk through some of the key components. But basically, there's your broad spectrum agents that are predominantly used for hospital onset infections. And so the way I think of this is your anti-pseudomonal agents. So it's going to be your anti-pseudomonal beta-lactams, aztreonam, your carbapenems, and your aminoglycosides. So that is one defined grouping that has its own predictive model to allow for benchmarking compared to national use from 2017. Another one would be broad spectrum agents that are primarily used for community acquired infections. And so this is going to be your second and third generation cephalosporins, primarily, as well as your fluoroquinolones. And of note, ertapenem shows up here. So because ertapenem did not have the anti-pseudomonal coverage, wouldn't be in the first grouping. Additionally, there's also grouping for gram-positive agents. So basically your anti-MRSA drugs. There's your narrow spectrum beta-lactams, so your amoxicillin, your amoxiclav, your early generation cephalosporins. There's a grouping for C. difficile infection risk. So these are going to be your antibiotics that are more likely to cause C. difficile infection. So specifically your later generation cephalosporins, clindamycin, as well as the fluoroquinolones. And then lastly, there's a grouping available for invasive candidiasis. And so these are going to be your antifungals, primarily your echinocandins, as well as fluconazole. And so basically, these are the predefined groupings that are available. Now, unfortunately, you cannot customize this, so I can't pick groupings that I'd like to see. We are limited by the constraints of NHSN with regards to what they have developed from that benchmark. But I think you'll see that they cover the majority of the needs and definitely give you a good starting point. So question 1 for the group, and just a show of hands is fine, but which of the following is an available SAAR antimicrobial grouping that we talked about? Would it be A, respiratory antimicrobials used for pneumonia? Would it be B, broad spectrum agents predominantly used for hospital onset infections? C, fluoroquinolone antimicrobials? or D, novel broad spectrum restricted antimicrobials for MDR pathogens? B, yep. So that was one of the first ones we talked about, so that would be B. All right, there we go. Yeah, so B. So the other ones are just ones that I made up, but really that is one of the more common SAARs that you're going to use, is that broad spectrum agents predominantly used for hospital onset infections. Way to keep that in mind would be your anti-Pseudomonas coverage. So now that we've talked about the AU module, what it is, what it consists of, really I think the next step would be understanding the considerations and limitations of SAAR. So what can it tell you? What can it tell you? And then specifically, are there any limitations or things that could be improved upon for the future? And so the first one to keep in mind is the consideration. So is it dynamic or static? So is it going to update in real time, or is this static and established to a benchmark? And the answer to that question is SAR is static. And so it's currently benchmarked against the 2017 national data for adults and for neonates, the 2018. And so what this means is that benchmark was established in 2017. And so even now, currently in 2022, that is still the benchmark that's being utilized for your SAAR. So it's compared to use for 2022. So I bring this up because one of the big changes I think we've all noticed, or I certainly have, and I've seen literature reports to support it, would be that COVID-19 had an impact on antimicrobial prescribing rates. And so I think the majority of facilities actually saw a relative increase in the antimicrobial prescribing rates, especially early on, before we had great ideas in terms of the incidence of co-infection. And obviously when admissions were relatively restricted, we're having more severe patients that are coming in. A lot of the patients that I saw early on in Michigan were getting at least cap coverage coming in before we were able to provide that data. And so what we noticed is that SAR data for kind of the surges did tend to increase. And so I bring that up to say that because it's a static benchmark, your specific number won't be affected by what everyone else in the nation is doing in 2022, 2021. So it's still going to be comparing back to 2017. However, if you're comparing your hospital to someone else's number for the same time, so they're going to have the same environmental effects. And so if you're comparing one facility to another, they're likely to have kind of similar environmental effects or regional effects. And so they may both appear elevated or not, depending on specific factors. But again, if you had the exact same relative use to the nation in 2017 and 2022, likely your number for SAAR is going to be a little bit higher in 2021 during kind of the peak waves there. So really kind of the key concept would be that this is a static measure. So NHSN does periodically update these benchmarks, but again, that last benchmark update would be in 2017. And now specifically, they're probably unlikely to use any of the COVID impacted data to establish a new benchmark. So I would guess, not officially stated, but I would guess that a benchmark update would be further from the impact of kind of the peak COVID waves. So another thing to keep in mind would be seasonality. And so Avdisian and colleagues in 2019 published an evaluation of the impact of seasonality on antimicrobial utilization data and SAAR data. And it was interesting that at their specific study site of practice, so Northwestern Memorial Hospital, they were able to associate seasonal variations of antibiotic use having an impact on your SAAR. So specifically, the use that was correlated was going to be kind of your agents that are primarily used during a respiratory season. So like azithromycin increase shot up substantially. There was some fluoroquinolone increase, and then oseltamivir was another one that increased. And so basically with the seasonality, the highest use tended to be during a respiratory illness season compared to other seasons. And so that's one thing to keep in mind, that if you're just comparing quarter to quarter, you may see some changes that aren't necessarily due to anything specific in your facility in terms of the long-term culture, but more on the impact of that seasonality. But by all means, not a definitive answer. And really the call or the conclusion from that study was that this is a component that NHSN could look to evaluate for the next benchmarking that's established. And so one of the things I really try to emphasize anytime I'm talking about this with any of my colleagues would be that SAAR does not have any impact on antimicrobial appropriateness, right? So we cannot make a determination using just SAAR alone whether prescribing culture at a specific institution is appropriate or not. So the key things to keep in mind would be an SAAR greater than 1 does not necessarily equal inappropriate use. So just because your SAAR is greater than 1 doesn't mean that you're using too much of that particular grouping. So an example of this would be if you're narrow spectrum beta-lactam agents, if the SAR for those groupings, so that's going to be your amoxicillin, your amoxiclav, your narrow spectrum beta-lactam agents that would actually, I think, all agree if you can use, we'd like you to use. So if this is greater than 1, that may indicate a strategic choice and show that the institution on average is using a more narrow spectrum than would be expected. So if that correlates with a use less than expected in your broader spectrum agents, then I would actually argue that's a good thing because you're performing better than the national benchmark. So just because your SAAR for that narrow spectrum group is greater than 1 doesn't mean it's inappropriate. And actually, in the example case, I would argue it's a good thing. Now, on the other side, just because your SAAR is less than 1 does not mean that you're using antibiotics appropriately. So for an example, let's say you have your broad spectrum hospital onset SAR being less than 1. Well, this may be inappropriate if because the reason that your use is less than expected is because actually patients are routinely receiving ineffective spectrum of coverage based on your institution's resistance patterns. And so maybe you're a site that has a significant population that's repeat readmissions, they're getting lots of antibiotics. And so when looking at your CAP patients, so let's say it's a severe CAP coming in, they have those risk factors. So your population on average has higher risk factors and your antibiogram supports that. So having an SAR less than 1 for that grouping may not actually be a good thing and may lead to undertreating your patients. So it's important to keep in mind and really trying to emphasize the fact that in general with antimicrobial stewardship, less is not always better. We want to make sure that we're optimizing use, not just reduce. And so the other thing would be the clinical context. So the SAAR metrics as a whole cannot provide clinical context of the prescribing culture at that institution. And so SAAR highlights variance or deviation from what's expected, but it doesn't provide the clinical context. So it won't tell you that the deviation from expected is due to overprescribing for intra-abdominal infections. So it does still require that clinical context, involvement of your stakeholders, potentially medication usage evaluations in order to determine, okay, what is actually driving the use that's greater than expected or the deviance from the national benchmark. And really combining it with on-site clinical context is what allows you to effectively design interventions. So having the people that are at the bedside, involving your pharmacists that are working the verification queue to see what orders are you seeing routinely. If you're a facility that requires the indication to be included with an antimicrobial prescription, then pulling those data to see, okay, for our anti-pseudomonal beta-lactams, by far the greatest number of chosen indications is pneumonia. So let's start there. So that clinical context is going to be really important when we're talking about deciding what to do next or where to go with this data. And now with SAAR, I think this is a field that's relatively new in terms of publishing what to do with it. And so there's a couple publications that I'll talk about as far as applying SAAR data. But in general, I think everybody's kind of at the standpoint of we're trying to use this as meaningfully as possible, but there's not a definitive answer in terms of this is the best way to use it in every situation. So the first one I'd like to highlight is actually a relatively new publication. And really, I think it's something that is a novel antimicrobial stewardship mechanism and something that I think is pretty exciting and definitely something that I want to apply to my practice going forward. And so Sheely and colleagues in 2021 published a prospective cohort study. And the purpose of this study was to examine the utility of SAAR reporting and inter-facility comparisons as a motivational tool to improve overall and broad spectrum antimicrobial utilization. And so what this means is they took the data, and so they had 3 reference sites, which we'll see, so hospital A, B, and C. And so they shared this data, and they actually fostered a spirit of competition within their sites. And so basically, by reporting the data to all 3 sites, making sure everyone was aware of their data, they allowed almost like a rivalry to develop to use as a motivational tool. And so they asked that the SAAR be reported at all meetings and be discussed. And obviously the goal was to decrease SAAR. Now you can see from the sites that there was pretty significant variation in terms of SARs for hospitals A, B, and C. So specifically hospital A and C started at a much lower SAR across the board than hospital B. And so the results of this study showed that one of the primary benefits was deviation and variation. And so they were able to decrease hospital B's SAARs fairly substantially, bringing them more in line with the other hospitals that were included in this study. So specifically decreases in all agents, all locations SAAR, as well as broad spectrum agents used for hospital onset infections in the ICU. And then, so all 3 hospitals actually did see a statistically significant decrease in their SAARs for those broad spectrum agents, but only hospital B had the decrease for all antimicrobials, all locations. So what they found is that by using this as a motivational tool, they were able to tap into some of the psychological nature of antimicrobial stewardship. And I think that's really one of the next frontiers, and obviously outside the scope of this conversation, but to bring it up to say that, I think we're all looking for creative and novel ways to increase antimicrobial stewardship efforts that don't require additional FTEs being devoted. And so this is something to consider. This didn't require somebody monitoring a queue, reviewing patients 40 hours a week. This is a competitive spirit, making people aware of the data and using something that they already had on hand in order to improve antimicrobial use. And like we talked about, so it led to overall decreases and specifically reduced variations between those hospitals in the same health system. So obviously, as a pharmacist that's at the system level myself, we have 19 different facilities. And so that's something that we're really interested in at baseline. How do we increase standardization and reduce variation? And so that's one thing that we'll be considering in the future. So another application would be looking at the effect of prospective audit and feedback and the impact of that on SAAR. So Lavorsky and colleagues in 2017 published a single center retrospective cohort study, and its purpose was to evaluate the impact of prospective audit and feedback on SAAR. Now, of note for this study, they did also specifically identify the inclusion of an infectious disease physician into this prospective audit and feedback process to have additional benefit. And so that was one of the focuses, but also what this impact was on the SAAR. And so starting prospective audit and feedback and including the infectious disease physician led to persistent reductions in the following SAAR categories. So broad spectrum agents used for hospital onset infections, broad spectrum agents used for community acquired infections, and anti-MRSA agents. So when we're thinking about stewardship interventions, those are generally the places we're going to be starting, right? Our broad spectrum coverage, our anti-pseudomonals, our anti-MRSA agents, and then secondarily to that would be your broad spectrum for community acquired. So your ceftriaxone, your fluoroquinolones. So a similar study also evaluating the effect of prospective audit and feedback on SAAR was Griebel and colleagues in 2018. And this was also a single center retrospective cohort study, again, evaluating the impact of prospective audit and feedback on SAAR. And in this case, again, prospective audit and feedback led to persistent reductions in SAAR. The secondary part of this study was, though, they looked at, did these reductions in SAAR have any changes on prescribing outcomes, patient safety outcomes? And the answer was essentially no. So patient safety and prescribing outcomes remain stable, or in some cases actually improved with the reduction of this SAAR. And so I think for those of us that are performing prospective audit and feedback on a routine basis, this makes sense. We're generally looking to get patients on the most appropriate antibiotic in the shortest amount of time for the right duration. So hitting all of your factors. So if you're increasing your prospective audit and feedback, that's generally going to lead to improved antimicrobial selection. And in this case, also led to reduced antimicrobial utilization at the facility, which I think, in my experience, I would definitely agree with. The last thing of note, and really the key takeaway for me from this study, was that they were able to demonstrate that SAAR values substantially less than 1 can be safely achieved. And so they ended up with values less than 0.8, in one case 0.6. And so because they were able to show that the patient outcomes were not affected by these low SAARs, that gives us confidence to say that we can do better than the national benchmark. We don't have to be limited by, okay, we got to a SAAR of 1.0 and stopping there. Because if in our clinical context, the overall prescribing still has room for improvement, then we're able to go lower than 1. And so now I thought it'd be helpful to talk through some case examples to kind of apply what we've talked about and go through how I would personally approach looking at your data set and making those determinations in order to design interventions and really plan your goals and take the next step forward. So for case 1, the context of this case is you're an antimicrobial stewardship pharmacist at a 250-bed hospital. Your facility is now participating in the NHSN AU module, and you now have access to both DOT and SAAR data. the goal of this case would be to utilize the AU data to decide on your next targeted intervention that your antimicrobial stewardship program will implement. And so we have case number one, which would be our SAAR data. And so when I'm approaching evaluating antimicrobial utilization data at a specific facility, one of the things that I like to do is to start at the kind of broader spectrum lens, which would be your SAAR data. And then you can use that to target in where you need to look a little bit closer. And so for this example case, we have a year's worth of data. So we have Q1 2021 through Q4 2021, and we have the variety of SAAR metrics that we've talked about. So specifically in this case, for convenience, I highlighted in red those metrics that are 1.2 or greater. So that would be on average at least a 20% increase in actual use compared to predicted use. And so one of the things that jumps out to me would be number one, we're seeing a lot of increased use compared to what would be expected for our gram-positive agents. So those are going to be your anti-MRSA agents, specifically like vancomycin, linezolid, daptomycin. And so we can see that on the general ward, so the third from the bottom, the gram-positive ward 2017, that actually across all 4 quarters, use was elevated compared to expected. And then when looking at the ICU, 2 of the 4 quarters, again, use was elevated compared to expected. Now, we do see some fluctuations as well in our broad spectrum hospital onset, our antifungals, our narrow spectrum beta lactams. But in general, I would say, when looking at this data set, my key takeaway would be that for whatever reason, our gram-positive empiric coverage is more than would be expected. And so based on the available SAAR data that we just talked about, what would be a reasonable initiative to implement? Would you, A, pursue carbapenem restriction criteria? We did see some increase in our broad spectrum hospital onset, which carbapenems would include. Would you consider B, mandatory ID consult for Staph aureus bacteremia? So we know from the published literature, right, that these mandatory consults do improve patient outcomes. So definitely a great thing to consider. What about C, a pharmacy-driven MRSA NARES PCR screening policy for patients that are on empiric anti-MRSA therapy? Or D, prospective and audit and feedback targeting fluconazole. And so we did see from some of those, right, that prospective audit and feedback can be an effective strategy. So what do we think? C? Yeah, so that's what I would choose as well. So we see that I think although all of these are reasonable stewardship interventions to pursue, by far the greatest outlier in the data set was going to be your anti-MRSA agents. And so that would be one method, which I think actually we have a talk later coming up on to pursue kind of bringing those in line with what would be expected. So continuing that same case, looking at DOT per 1,000 patient days, this can be useful in determining which antimicrobial is driving the bulk of the elevation in SAAR. So we know that as a whole, that preset NHSN standardized grouping of the gram-positive agents was elevated compared to what we expected. But if we want to get the most bang for our buck, we can look at the DOT data to determine, is there one specific antimicrobial agent that's driving the majority of use, or is it elevated across all the agents in that grouping? And additionally, this data set can also be useful for tracking changes in over time for that specific antimicrobial that we're talking about. And so we have the components of that grouping. So we have vancomycin, daptomycin, and linezolid at the same example hospital. And so looking at the pie graph, we can see that vancomycin actually makes up about 90% of the just the overall anti-MRSA therapy at this facility. And daptomycin makes up about 8% and linezolid makes up about 3%. So pretty consistent grouping towards vancomycin is driving the use potentially. And so that brings me to the third question, which would be based on the data that we just talked about, which anti-MRSA agent would you focus your prospective audit and feedback efforts on? Would it be A, vancomycin, B, daptomycin, or C, linezolid? I think everybody agrees it would be vancomycin, right? If you're having something that's driving 90% of your use, it's probably a reasonable place to start. And so now looking at case number 2. So in this case, you're a system level antimicrobial stewardship pharmacist for a health system with 3 hospitals. And so you're tasked with reviewing last year's NHSN antimicrobial utilization data to determine system goals for your stewardship program for the coming year. And so this is another view. And one thing I will point out is that NHSN, some of the data set that you get, while robust, some of the data analysis views tend to be a little bit limited. And so for our facility specifically, I created an Excel dashboard with all of these customized views in order to more quickly interpret the data set and allow all of our 19 facilities to have access to this. So we have pre-established slicers, as well as some conditional formatting in the Excel database to allow for quick analysis depending on what we're looking at. And so that would definitely be something I would encourage anybody that's using current NHSN data to think about as a way to kind of speed up that review process and make it a little bit more meaningful. And so for this example, for Hospital A, we look at the top 10 SAARs that are elevated. And just for convenience, I put a red line at 1. So anything that has a bar to the right of the red line would be that their SAAR for this data set is going to be more than 1. So you can see at the top are antifungals in the ICU, our gram positives in the ICU and ward tend to be reasonably elevated compared to what would be expected for that hospital. For Hospital B, again, similar trends popping up. So again, our antifungals tend to show up at the top, specifically in the ICU, as well as the ward. Our gram positives are showing up as well. And then for Hospital C, again, antifungals in the ward, antifungals in the ICU, gram positives in the ward. So we're seeing kind of similar themes develop at these 3 hospitals with regards to the SARs that are the furthest from 1. So in talking about that data set and looking at the top 10 SARs, what conclusion can you draw about all 3 facilities? So a show of hands, would it be A, anti-MRSA agent use on the general medical wards is inappropriate? Would it be B, all 3 hospitals use too many antibiotics overall? Would it be C, all three hospitals prescribe excessive antifungal therapy in their ICUs? Or D, antifungal use in the ICUs is greater than would be expected for each hospitals given their specific factors? So in this case, it's going to be D. So while C and D may seem similar, this pulls back to the clinical context that we talked about, in that just from the SAR alone, although I think we would reasonably agree that when you're seeing 50+% elevations compared to expected, there's probably something going on there. The more accurate contextual determination would be that use is greater than expected for those hospitals. Same reason why A would be wrong is that we're making that determination on inappropriate. Same thing with B and C as well. So in summary, I think there's a couple of key takeaways that I want to make sure that we're all on the same page with regards to using NHSN to determine your next steps for your antimicrobial stewardship program and really understanding the components of the antimicrobial utilization module. So specifically, there are several preset groupings of antimicrobials that are available for SAAR data. And so that's a great starting point. So looking at your SAAR data over time with those preset groupings, you can kind of scan, get an idea of the layout of the land. But one thing I would point out is some of the groupings do tend to be pretty broad. So specifically your broad spectrum hospital onset infections, that includes all of your anti-pseudomonal agents. And so you'll need to drill down a little bit further if that's elevated, because it may be that your cefepime and piptazo is driving that use, but it may be that your carbapenems is driving that use as well, specifically with meropenem. So keeping in mind that gives you a good starting point on where to focus, but then drilling down a little bit further can, I think, have a higher yield. And that there is highlighted areas of variance and deviations from expected use with NHSN SAR data. So you're able to see what is different than what we expected, whether that be in the positive side or the negative side. But again, without that clinical context, you can't make determinations on appropriate or not appropriate. And then lastly, DOT data can aid efforts to identify which antimicrobials are driving those elevations in your SAR data, as well as allow you the ability to track changes over time. So in general, kind of my approach is starting with the SAR data, getting an idea of where to look, pulling into our DOT data. And so one thing I will emphasize as well is that you want to make sure that you're not getting caught up in the balloon effect. So I'd recommend, if you're looking at your DOT data, to not look specifically at your cefepime DOT or specifically at your piperacillin tazobactam DOT, because if you're driving use from cefepime to piperacillin tazobactam, if you're looking at just those, you'll see one went down, one went up. But overall, your anti-pseudomonal beta-lactam use is largely the same. So we have preset groupings at my facility. So looking at our anti-pseudomonal beta-lactams, our carbapenems together, our empiric anti-MRSA agents together, fluoroquinolone. So having those groupings so you're able to assess kind of the therapeutic class as a whole and not necessarily one specific agent. And so with that, I thank you guys for the opportunity to speak with you. Welcome any questions that anyone may have. And yes.
A lot of been struggling with as far as getting that comparison data with similar institutions. Maybe like, would you give us a cheat sheet maybe session?
Yeah.
How to do that? It is there somewhere.
Yeah. So the key thing is. Yes. So the question, as I heard it, was struggling to actually use the data set that's available to compare to different facilities. And so definitely the request was to talk about maybe a cheat sheet after the presentation, and I'd be happy to do that. One of the most important things I will say is you have to have access to the facilities that you want to look at. So if you don't have access to more than one facility within your health system, then you won't be able to compare that data. So as a system level pharmacist, I have access to all of our facilities. And so myself and my partner are able to download all Ochsner facilities data and put it into our database. So that would be kind of the key starting point.
I guess what I meant was on a single facility in Medmont, I had access to national comparison data, which when we switched, I lost that. We have access to like similar some educational, state, and national. Like, does NHSN offers that?
So unfortunately not. So that would be a MedMind specific feature. So specifically with NHSN, you can have the SAAR data to compare to the entire nation, but they don't have regional breakdowns or anything like that for facilities that you don't have access to the data for.
And I just wanted to add that that's part of our goals of public health, because we do have access to the facilities who do report to AUAR, but we'll just have to figure out what that timeline looks like to actually get those data back to you all for comparison. So just want to let you all know that that's something that we're in progress with.
Thank you. Yeah, I think that's exciting to hear. All right, well, thank you, everybody.